thank you very much for coming. So today's online event is looking at communicating with your GP as a pituitary patient. So what I'm hoping to do today is to help you to get the most out of GP appointments that you go to. Feel confident when you're approaching your GP, whether that's something to do with your pituitary condition or even just a more everyday condition that you happen to be going to see your GP with. Really, it's all about advocating for yourself when you've got a rare condition like we do. And the ultimate goal is really to feel prepared, whether that's prepared for the long-term issues that we all have, shorter-term ones, so that's the acute stuff, so short-term problems and illnesses, and even emergencies. So, things that you might have to think about your sick day rules for, or other sort of acute medical emergency type problems. Nice little scout badge for us to all hopefully achieve by the end of this session. There we go, let's move on. So who am I? I'm Jenny. I qualified in Brighton in 2012, which now feels like donkey's years ago. I finished my GP training in 2018, which is partly, the big 6-year gap is partly because GP training takes quite a long time, and partly because I had quite a lot of time out being an unwell pituitary patient. So 2015 I was diagnosed with Cushing's disease. So I went through the diagnostic process for all of that in Oxford was where that was based for me. Had surgery for that, and now live with adrenal insufficiency following on from all of that, which some of you may be familiar with if those are conditions that have affected you as well. So I'm now quite recently, actually, just end of last year, a volunteer for the Pituitary Foundation Medical Committee, which I'm really enjoying. I was actually really pleased to be able to get involved with that because the foundation was really a very useful resource for me, myself as a patient, when I was quite poorly with Cushing's. So it's lovely to be able to give something back, I suppose. So that's what I'm doing that. Currently, I'm taking a career break, so I haven't been working as a GP for the past couple of years, and this is my little my little reason. He's a bit monster, but he is pretty cute in a little suit going to a wedding, so we forgive him. That's Rowan. He's almost 3 now. I did go back to work after he was born, but parenting combined with dealing with adrenal insufficiency, dealing with work, it wasn't all going to happen, so I decided to just take a break. But I'm very much enjoying being able to keep a little bit of medicine going in a useful way, doing this stuff, which is really lovely for me. Anyway, enough about me. I'm more than happy to answer questions about my own experiences and medical stuff if it's helpful to any of you, if being able to relate in that way is useful. But it's not about me, so I've left it brief for now. There we go. So I thought a good place to kick off would be to see if we could maybe brainstorm together. How do you feel? What are some of the emotions and feelings that you experience or have experienced when you go and see your GP? So I'm going to come out of screen sharing briefly. So some of the things that I thought of when I was writing this, when I was brainstorming these thoughts, are the things that I've put in the clouds, really. I know when I've, strangely enough, being a doctor doesn't actually help that much when you're a patient as well and you're going to see your own doctors, whether that's GPs or specialists. You're very much in a different boat and wearing a different hat. So, some of the things that I associate with those experiences are feeling worried, feeling anxious, even feeling intimidated. overwhelmed. There's a lot of frustration involved, particularly when you feel or you perceive things are not quite going your way, and that can be very hard to manage. I've actually put a couple of positive ones in there as well. I've put hopeful, I've put reassured, because there have been times when I've gone to see somebody. There's a particular GP I have in mind who did help me to feel hope and helped me to feel reassured. And it really makes a difference when somebody helps you to feel that way, which is why I feel quite strongly about this, this patient-doctor relationship stuff, and how important it is to have that trust and that therapeutic relationship, because it does make a difference. Where are we going next? Let's see. So the next thing is the thing about pituitary stuff is that it's, in the grand scheme of things, it's really pretty rare. It doesn't feel like it's that rare when you're submerged in the endocrine and pituitary world, but it is in reality. It's, GPs might only see 1 or 2 pituitary patients in their career, and as we've just covered, it's really common to feel anxious and worried about seeing your doctor if you've got a rare disease, and it sometimes can be helpful, or at least helpful. It was helpful for me to think about how it is on the other side, how doctors feel about having rare disease patients. I mean, maybe I think about that more because I'm sort of wearing both hats quite a lot of the time, but it is interesting. There's a concept in medicine that most doctors are familiar with, most GPs particularly, because we deal with common everyday conditions that you see in the community a lot. And the quote is, "When you hear hoofbeats, think horses, not zebras." That's probably something that you have heard as well. The idea is that we are trained very much to think along the lines of common things are common. Symptoms are vastly more likely to be down to a common illness than they are to something weird and wonderful and exotic. Not to call any of us weird, but definitely to call us all wonderful. So the mindset is particularly when we're talking about diagnosing these conditions or considering them in the first place, the mindset is often not geared very well towards thinking about rarer things. But of course, for us, and lots of specialties, every specialty's got its rare diseases, but in endocrinology, pituitary stuff is quite rare. Sometimes it is a zebra, and it's worth us and doctors remembering that these things do happen to people. So this is, I hope that you can all see this okay. It's a screenshot from a paper online. I can read it on mine, but do shout and let me know if you can't see it, and I'll try and do something different. This is just something I found quite interesting when I was doing my research, and it's a qualitative study that was done looking at physicians, so both primary care, so GPs, and specialists in Europe, in the UK, in America, and it was looking at emotions that physicians experience when their patients have rare diseases, when either they get a diagnosis or they're looking after patients with rare diseases. And I just thought it was quite striking how similar some of those emotions are. So we've got challenged, intimidated, frustrated, overwhelmed, nervous, hopeful. That's a nice one. I just put these 2 in pink because I don't know about you, it quite tickled me that feeling excited was associated with being an endocrinologist. So we can rest assured that at least our specialists are excited to look after us. Slightly flippant, and I do apologise for that, but I enjoyed that little fact. So that was in the Value in Health journal a couple of years ago, but it will be as applicable 20 years ago as it is in 20 years time. I think it just shows that, you know, there are feelings and worries and insecurities on both sides of that relationship. So I thought that we would move on to some common worries that I have experienced being a patient, that I suspect most of you probably will have thought about or worried about from time to time. And what I'll aim to do is, in the rest of the presentation, sort of address each one of these and just talk a little further around these areas. You know, and if there's anything that occurs to you whilst we're going through them, just make a note. We can come back to it at the end and see if we can come up with some answers together. So the first one, I think somebody alluded to this just before, and that's, will my GP know about my condition? Will I have time to explain things? Can I see the same GP each time? Will I be able to get the medicines that I need? What about my tests, my results? Those are some things that came to mind immediately for me, thinking about things that might be on my mind if I'm seeing a GP as a patient. Now, if we think, what might the GP be wondering about? What's going through their mind in these consultations? It's for me at least, you've got half a mind on talking to the patient and taking their concerns on board, and half with a medical brain thinking, what else does this affect? What should I worry about here? What are the medication interactions? What could be dangerous? You know, is there something that this condition makes dangerous, even if ultimately it's quite a common illness for most people? Other things, for example, when should I be referring to the endocrinologist? What's the scope of my role here? What should I be doing? What's more appropriate for the endocrinologist to do? Those sorts of questions. So why is communication so tricky? That's a loaded question, isn't it? But why is it? I mean, it is difficult, but why is it difficult? So, I mean, tons of reasons, but I think some of the important ones come down to, it can feel like doctor and patient might have different priorities. You know, some of the things that the GP is going to have to think about are not going to mean much and not going to be important to a patient, and that can cause misunderstanding on both sides, I think. And the thing that really doesn't help with that is the 10 minutes. It's horrible. We hate it. Patients hate it. We hate it. It's not enough time. It's not enough time to do anything. I have never once in my entire professional life managed to consult in 10 minutes, I don't think. I get in trouble for running late, and that's just how I roll. But it's difficult, and it leads to a lot of anxiety on both sides, I think, because it's never long enough to get what you need out of the appointment. Emotions are a big one. I think emotions do affect how we communicate and how effectively we get a message across. There's sometimes also, as I mentioned before, some uncertainty about who should be doing what and when they should be doing it, and that can cause confusion. It can cause friction. It can cause irritation, and all of these things can get in the way of what should be a supportive and helpful relationship. They're just useful things to think about, I think. So I wonder, how can we help each other? So if we just go back to that list of questions that I was pondering. So the first one, will my GP know about my condition? So I apologise, I think the next few slides are quite busy, but hopefully they're legible. I think the most important thing here is that you are the expert patient. the reality is that a GP is unlikely to be able to answer questions that have very specialised answers or require very specialised knowledge, because they're not going to have come in contact with that. In fact, actually, there are times when even endocrinologists who haven't specialised in pituitary medicine might not be able to give all the answers about specific pituitary issues. So it's quite a niche area, and that's difficult as a patient, because nobody likes to feel they've got something that nobody understands. That's a horrible feeling. But you are the expert in your own condition, and no two pituitary patients are going to be the same. So even if you have the same condition, technically on paper as somebody, it's going to be different for you than it is for the next person. I think the thing to remember is that a GP can phone a friend. GPs can ring and get advice. They can, maybe even they don't ring, they can email, or they can find out advice from specialists or Pituitary Foundation, for example. You can also directly approach specialist teams and helplines. I know I've done that on a number of occasions when I've been worried about something and I haven't been able to find the answer. For me in Oxford, it's the Bagot and Drake ward, which is where the endocrine nurses are based. Yeah, it's not particularly helpful that I don't have that information for all of you, because I don't know where in the country you're based, but most NHS trusts will have, and endocrinology departments will have either a helpline or a team of specialist nurses who are there to help you with queries. So where I've put the little light bulb there, I've aimed to just brainstorm a few tips or ideas of things that can be helpful. So one thing that somebody else told me this, actually, and I cannot remember who now, but I remember thinking it was just such a good idea, is that when you get a leaflet, like a patient information leaflet from either a hospital or a specialist clinic, give it to reception at your GP and ask them to scan it into your notes. And that, it seems simple, but it can actually be really helpful, because it's usually a very concise overview of what's wrong with you. And it might not be written in medical jargon, but it certainly gives an outline of what's wrong, and it gives pointers of where to go for more information or more medically leaning resources if that's needed. But it's a really good quick introduction to what's happening. There's also which I would like to say all GPs know about it, but I suspect that they don't. There's the Pituitary Foundation itself has got a fact file which is written for GPs, and it's basically a pamphlet that sort of outlines the most common pituitary conditions, what needs to be done in primary care, what the best practice is, when to refer to endocrinologists, that kind of thing. And it's long enough to be useful, but short enough to be concise enough to go in someone's notes, I would say. So that can be a helpful thing to either give your GP or ask for it to be on your notes in some way, or it's something that you can discuss with your GP yourself if you feel that's helpful. And just back to the expert patient stuff, it's really important knowing what are the risky things for you personally. So like I was saying, every pituitary patient is going to be different. So for me, for example, with adrenal insufficiency, one of my individualized risks would be vomiting. So if my toddler catches yet another toddler bug and is vomiting, that's more dangerous for me, because I'm not going to keep my steroids down. And I have twice now ended up in hospital with an adrenal crisis because of a diarrhea, vomiting and fever bug that my darling child has passed to me. And it's just knowing about those sorts of things which might not, that's such an important example that that itself probably would be recognized, but there will be other more individual risks that are important for you to know about, so that you can communicate that. one example I can think on that one would be if you're given, for example, some antibiotics for an infection, a completely unrelated infection, by your GP, but one of the side effects is possible vomiting. It might be that is quickly mentioned, usually in a consultation, about vomiting as a side effect to most patients, but is not thought to be that dangerous. But actually for you, it may well be very dangerous if you're vomiting. So that would be, do you see that's what I mean? It's very individualized what's going to be more risky for you. And I think one way of helping with this is to always have this question in your head when, you know, if you're going to see your GP about a non-pituitary thing, about just some other medical condition, whether that's a long-term thing or whether that's a short-term illness, never be afraid to ask or to sort of highlight that I have a pituitary condition, and is that going to, you know, is this treatment or whatever's happening going to affect my illness or my treatment? You know, if I'm taking pituitary drugs or I've got pituitary issues, is that going to get in the way or make any of this different for me? You know, that could be anything. It could be flu, cough, infections. You know, they all have different sorts of treatments. It's worth just having that in mind to ask. And I know I've done that myself just to make sure. Yeah, so the next one we were going to talk about is, will I have time to explain things? And if you'll forgive me for for being blunt, no, probably not, because there's just not long enough in a single appointment. And it's one of the things I think is very helpful is booking double appointments. I've done this a number of times. You occasionally feel like somewhere along the line someone's raising an eyebrow about you booking a double appointment. I know I have when I've been feeling a little more self-conscious. But ultimately, it is totally justified. We've got difficult, complex, and confusing conditions. And if there's stuff that needs to happen, things that need to be discussed, it's a lot less fraught if you can have a double appointment to give time on both sides to process all of that. And it is on both sides, because not only are you going to feel less anxious if there's less time pressure, but if I put my GP hat on, I know I feel a hell of a lot less anxious if I've got a double appointment with someone and I can give the time that it needs. Of course, 20 minutes is often not long enough either. And sometimes it does mean coming back time and time again to get things properly sorted. But double appointments can be useful if you're able to book them. Obviously, completely recognise that in itself is quite difficult sometimes when there's huge pressure for appointments. But it's worth bearing in mind as and when you can do that. Other tips, quite simple ones here, things that I need to do when I'm a patient. I bring a list, I write down all my questions, and I bring a shopping list of things that I need to talk about, because I just won't remember them. And if you're anything like me, when you're in a flap and a fluster because there's something wrong, you just can't remember it all. So a list is really helpful. I love it when a patient turns up with a list. It's fantastic, because I just go through it with them. And yes, often have to say, we haven't got time for 4, 5, and 6, but let's do 1, 2, and 3. And it helps just, it helps both parties, I think, feel that they know what to expect in the appointment and what we're going to cover, and not forget things that are really important, and maybe to prioritize what's most important to address in those 10 or 20 minutes that you've got. Just bear with me. Bringing a person is great. I've done that when I've been unwell and not able to do it on my own, basically being a person, a second brain and a second memory, somebody to make notes, take minutes, if you will. That's a really good idea too, if you're struggling with things. So can I see the same GP each time? There's a question. So this is something that I care a lot about, actually. This is a quote from a couple of researchers that I liked. And it's few things in medicine have as much evidence supporting their effectiveness as continuity of care. And continuity of care is basically seeing the same person enough that you have an effective and therapeutic relationship with that caregiver or person. And over time, there's a mutual understanding of what's wrong, how each other work, how each other communicate. And it has been shown time and time again that that is really important for people getting better and living as well as they can, and a whole host of other things. I have a favourite GP and I can't always see her. I have asked them to put a little note on my record that I want to see this doctor, if possible. It's not always possible, but it's there, and it just means if it is possible, they do book me with her. That is something that you can think about doing. It comes up as when the reception team click on your record, it brings up a little box that says would like to be booked with X doctor. So it's something that you can certainly ask for. The other thing I think is useful is, particularly for us, not everybody, not all of us, but a lot of us will be on long-term or lifelong medication, and that leads to having a yearly medication review. And that can be a really good time. If it depends how it works in your practice. So some will have a face-to-face, some will do it over the telephone, some do it over video, some do it sort of an online check type thing. If you can have face-to-face or telephone, obviously that's preferable. And we all know the pressures that currently exist in general practice, and it's sometimes very difficult getting appointments. Obviously, I don't need to tell any of you that. But if you can, then the yearly medication review can be used to just teach your GP, educate us, tell us about your condition, what's new over the year. Is there any new developments, any changes to your treatment? Has the specialist told you anything new and useful that might not have filtered through to the GP records yet? I think the reason why this stuff is important is that it avoids that scenario of starting from scratch every time you see someone, which is always really difficult. I thought now would be a good time to put in something about the summary care record, and I don't know how much you know about that, but it comes under the heading of continuity of care, and people who might not know you looking after you. So the summary care record is basically a big database of health information from your GP record that allows people, staff members in more acute settings, so out of hours or A&E, the ambulance service, for example, to see a concise summary of your problems and your medications, allergies, that sort of thing. Things that are sort of vitally important to know in an emergency situation. And the reason it's important to know about this is that the old system that the ambulance service used to use, which was called the red flag system, is not being used anymore. And that was, it was quite relevant to pituitary patients, because there are a lot of us who have red flags on our notes for one reason or another. For me, for example, it would be adrenal insufficiency. So that would have flagged up if I phone an ambulance from my home address. and it would flag up saying, this person is at risk of having an adrenal crisis, go there fast. It doesn't do that anymore. I mean, it sounds dreadful, but there are actually some pretty good reasons why it's changed. One, not least because that system relies on you being at your home address and phoning from it for that red flag to pop up. And if you're not at home, that's not particularly useful. The summary care record it has the potential to be a very useful summary that can be accessed immediately by ambulance staff or out of hours, etc., to find out quickly what's up. So there is a whole bunch of other information about what needs to be on that, and it's things like making sure that your medicines are up to date, that your main problems are coded in the most accurate way, that your any emergency drugs that you might need to have access to need to be listed on your current medication and not your past medication. The reason that's important is because if you take, for example, emergency hydrocortisone injections, they get prescribed once in a blue moon and you hang on to them until you need them. And that tends to mean that they don't end up on your current regular medications. They end up relegated to past drugs or one-off drugs. And that means they don't show up. Well, I think they show up for a year or so on your summary care record, but eventually they fall off and they're not there anymore. And that obviously can be dangerous. So the letter that I'm referring to here basically just outlines for your GP what needs to be on it and why, and asks them to make sure it's all up to date. It's got the right codes, it's got the right information, that sort of thing. There's other things that you'll probably be more familiar with: emergency steroid cards, patient passports, things that you can carry with you on your person that immediately alert somebody who might be looking after you in an emergency to what you need. Okay, so medicines next. Can I get the medicines I need? Generally a huge source of anxiety. After all, most of us here, I imagine, are on drugs that we really, really, really need, and not having access to them is incredibly stressful. So again, a really busy slide. I apologize for that, because it's a busy topic. So extra supplies, that's a really important thing to make sure that you've got. If you take something which you need varying or variable amounts of, for example, if you take something that you need more of when you're unwell or in certain situations or taking certain drugs, that sort of thing, it's useful to have, well, it's not useful, it's imperative to have extra supplies, emergency supplies at home. You can of course get urgent prescriptions if you don't have enough at home. You can get an on-the-day appointment as an emergency to make that happen on the day if that's needed. Ideally, that can be avoided if you have longer prescriptions, and the endocrine advice is generally 3 months for our sorts of medications. I think that's been a bit difficult recently because a lot of GP practices have now been advised to only give a month of routine medicines, which of course is a complete nightmare for everyone, but particularly if you're on something important that you need excess of. The main thing is not to let your supplies run too low before you're reordering. Obviously, there are. I know most practices have got limits on when you can reorder, and when you go to do it online, it says you can't order it yet. You've got to wait until X date. So there's sort of practical limits like that, but you can what I've done sometimes is just ask for an extra lot to put aside at home for times when my toddler's given me some lovely vomiting bug, as I've mentioned. There is some work going on currently by the Pituitary Foundation, which I'm involved or going to be involved with, which is more letters, more letters for GPs, basically asking them to use some discretion with the 28-day prescribing rules, and for long-term, or well, in our case, in pituitary conditions where it's advised by endocrine specialists that 3 months is a good amount to be given in one go, if they could consider doing that. And you know, the letter will involve some information why it's important, and what the rationale for that is. Obviously there can be some compromise if they can't or won't do 3 months, then 2 months would be better than 1 month. It's just about trying to have that discussion and that conversation to see if that can be arranged in certain situations. Oh, the next one, so needles and syringes and that kind. So this one applies to me and probably several of you. Having needle and syringes ready to do emergency injections if you need them. I was given mine initially by my endocrine team. Of course, they expire, all of the vials and so on expire after a certain amount of time, so they need reissuing. And it's just a good idea to try and find out well in advance where you'll be able to get that from, so that you're not panicking, trying to get it at short notice, having it at home in stock, you know, a couple of options to have for when you might need it. And again, important to remember that that's on your, that sort of thing is on your current medication and not your past medication. The next point is an interesting one, issues around changing brands of medication. The issue with changing brands is that your pharmacist might need more time to get a certain brand in. I know that's happened to me when all they've got is one brand and you want or need a different brand. That needs taking into account in terms of when you request medications. If it's not the brand they happen to have in, then they're going to need a bit more time to get that and restock it. Your GP can prescribe by brand in some situations, can't in others, and sometimes won't for other reasons. I find that a little bit confusing, the exact issues, you know, the exact reasons why we can or can't, and often it's a case of being told by the medicine's powers that be that you need to do this and not that, which can be incredibly frustrating. And it's always worth having a conversation if you feel strongly that, you know, that one brand suits you over and above another one. Often that can be accommodated if it's causing a problem for you. The practice pharmacist really is your friend here, and they are a great person to get to know. Obviously, not over coffee, but they can often give phone appointments for advice, and they often have a knack for finding out information about sourcing medications, particularly if they're not particularly common ones. The next few points I think we've covered mostly, about the emergency drugs and needing to be on your current medication for the summary care record and so on. The next one is just worth mentioning if you are someone who does self-injections or might need to in an emergency situation. Do you need a refresher on that? Have you watched the video recently on how to do it? And do you know where to find that? So I was shown initially by the endocrine team. Obviously, have done plenty of intramuscular injections myself in a professional capacity, but it is different when it comes to doing it yourself when you're poorly, I have to say. It's a different kettle of fish. So it was useful even for me. So it's certainly worth refreshing your skills in. And if you go to the Pituitary Foundation website, there's links to online tutorials, YouTube videos, that kind of thing, where it talks you through it. So tests and results next. Right, so, formatting's gone a bit funny on that one, I do apologise. I've broken this one down into a couple of areas, and the main issues, I think, with tests and results are usually things around who should be doing what, where should certain tests be done, and where should they not be done, and who should be requesting them and looking at the results and that kind of thing. And there's some really important issues around that need to be got right, really, for everyone's, particularly our benefit. So I'll split them into practical things and safety things. So when pituitary patients particularly often need to have blood tests done that are quite specialised and not your normal routine bread and butter tests. It can sometimes cause a problem if somebody tries to request those in the wrong setting. So if you try and request some of these specialist tests in general practice, one of two things could happen. Either it's physically taken out of your arm, but it isn't able to get to the lab in the right time frame for it to be analysed properly, and so it's completely wasted. That's one danger. And some of them we physically can't do. I've tried to request things in primary care, and you basically get a message up saying computer says no, send it to a specialist, you're not doing this. So sometimes it is as simple as it physically can't be done in general practice, and sometimes it's more that it's not sensible to do it in general practice because, I don't know, it needs to be in the lab in 20 minutes, or it needs to travel on ice, or it needs to any number of things where you're testing weird and wonderful things. So that's the practical stuff. The safety issues are probably the more important one. And I know I've personally found it slightly frustrating sometimes when you're desperate for some results that you've had done, or you're desperate for the results of some tests that you've had done. And it would be great to be able to phone up your GP and get the results and go about it that way, because it's not always easy to get hold of a specialist, or wait for, or particularly when you're anxious, wait for a letter outlining your results or something like that. The problem sometimes can arise if you've had specialist tests done. There's another generally accepted concept in medicine is that if you have a test requested, it really should be the person requesting it that interprets that result, because they're going to have requested that blood test in full knowledge of why the test's being done, what the implications of it are, and how to explain the results. And that's important in any situation, but it's more important when the condition or the test is very specialised and not your run-of-the-mill full blood count or whatever. And I think it comes back to the zebra thing again. So I don't want to generalize, but our normal is generally not everybody's normal, and it can be that even for more normal sounding blood tests, even if it's not specifically a weird and wonderful test, we can have results that are unusual. So we can have results of normal tests that don't look the same as patients that don't have pituitary disease, and that can cause an issue if someone is trying to interpret those results outside of a specialist context. And I've got some examples of that to come, which you're probably familiar with anyway, but we'll go through them for completion. I mean, the worst case scenario is obviously if somebody interprets some blood tests wrongly because the context isn't quite right and ends up making changes to medications or something like that. So I think the most obvious example is probably with thyroid issues, hypothyroidism. So vastly the most common type of hypothyroidism is a problem with the actual thyroid gland itself. So nothing to do with the pituitary, nothing to do with poor functioning of the pituitary gland. It's just that the thyroid gland is not able to produce enough thyroid hormone. And in that situation, the way you think about the results is you look at the TSH, so the thyroid stimulating hormone, and you use that to guide treatment in a normal circumstance. In pituitary hypothyroidism, I'm probably teaching you to suck eggs now, but it's a useful illustration of the point that I'm trying to make. So in hypothyroidism caused by a pituitary problem, you can't use the stimulating hormone because that's produced by the pituitary gland, and in certain pituitary conditions that is low all the time because your pituitary is not producing it. So for me, for example, when I have my thyroid done, because that was damaged when I had the surgery, I now don't produce very much stimulating hormone from my pituitary, which means that it always comes back low, which in a normal patient would look like I was over replaced. So it would look like I was taking too much thyroid hormone tablets. And the usual conclusion, therefore, would be that I need to take less of it because it's being, the amount of thyroid hormone in my system is clearly suppressing my stimulating hormone, which is what would happen in the normal setting. Obviously, that's not the case. It's low because it's always low because that's normal for me and possibly several of you. The important thing being that we rely on our T4, which is free thyroxine, to guide treatment. So it's the level of actual thyroid hormone in blood that's used to see if we're on the right levels and not the TSH. If you follow that through to the natural conclusion, that the worst case scenario would be someone is told that their TSH is far too low, they need to reduce their dose, and they do so, and obviously that's the wrong answer for them because we've not thought about the T4 level. The next example has happened to me a couple of times, and it's not, it works the other direction. It's not particularly dangerous some of the time, but I've had tests done for morning cortisol, for example, which has come back super low because it's always super low if I haven't had my hydrocortisone in the morning. But of course, the poor GP getting that message in their inbox first thing in the morning has an absolute panic if it's not labelled properly because they think, oh Christ, there's someone having an adrenal crisis in the community, what do I do? Which obviously is not the case, but it sort of illustrates how context is really important and how it's important that the person who's requested the test reviews those results because they're going to have that context and that understanding. So I think the important things for us to remember is knowing what our targets are. I mean, the thyroid example is know what your target TSH is, or equally know if your TSH is just not useful to use at all. And in that case, it would be knowing your target T4. And also just ask, really feel free that you can challenge people if they give you a result that's not expected or an action based on a result that you're not 100% sure about, then just query it and make sure that you're happy with that before acting on it. There are a couple of things that can be quite useful, and your target TSH, for example, can be written on the prescription, and it should be the sort of information that's written on the blood request itself. just so that that's right there in someone's face when the result comes back. So the next and final thing I wanted to just touch on, if that's okay with everyone, is the emotional side of things. I don't know about you, but I find it really quite tough living with pituitary problems. Sometimes it can be a lot. It's a long-term condition. You take lifelong medications sometimes. Some of those are going to come with side effects. We often are going to have symptoms just as our normal. You just have to get used to a new normal, and that comes with symptoms and problems. And it's difficult to go from healthy and problem free to, oh, there's something wrong with a really, really important gland in my body, and that's going to have knock-on effects everywhere, and that's difficult. Things that more specific to pituitary problems can be things like dealing with physical or bodily changes. My own example, Cushing's, there are quite striking physical changes that come with that, and that's really difficult emotionally. And it's also the sort of thing that people seem to find quite difficult to bring up and help you with, because it can feel a bit awkward. So there's a danger of it being slightly brushed under the carpet, I think. The other big one, I'm sure all of you are familiar with, people saying, oh, but you look so well, or you look like you're doing great, that kind of thing, which is really well intentioned, but it can be difficult when you hear it time and time again and you think, well, I'm not well, actually, I feel dreadful all of the time, so thank you, but no thank you. That's hard. I think that the reason I just mention all of this is because as a GP, I'm used to seeing quite a lot of mental health related things because it's common in the community. We see a lot of it. But what's not so common is dealing with the specific mental health challenges and emotional challenges that come with long-term illness and come with rare illness. And there are services that cater more specifically to that. So that even in NHS services, there are therapists that specialise in helping people deal with the emotional toll of chronic and rare illnesses. There are waiting lists, of course, as with everything, but it is worth asking to be referred. If it is something that exists in your area, then you should be able to be signposted to that, and perhaps a more specific referral could be made if that sort of provision exists locally for you. Then that's a way to go sometimes. And definitely not forgetting patient support communities, which are fabulous sources of support, online or in person. I'm quite shy sometimes, so I probably would start online rather than physically going somewhere. But it's there are different sorts of communities that exist, and it's just about finding one that helps you. So that's worth looking into. And the Pituitary Foundation has got quite a bit of information on the website about all of that. So not specifically related to general practice, all of this stuff, but your GP can often refer you to talking therapies, and if there is a local option for something more chronic illness related, then that might be something they can help with. I know when I worked in Reading, there was a local service that had that capacity. I think it's going to be a bit of a lottery where does and where doesn't, unfortunately, as with everything, but it's worth knowing about. Yeah, okay. So this is just back to the aims slide. Hopefully we've gone through most of these things: chronic, acute, emergency issues, a few tips, hopefully some tricks for feeling a bit more confident advocating for yourself, because it's tough doing that. It's difficult trying to get what you need out of a situation, I think. I think that's probably the end of slides as far as I'm concerned. So it'd be really nice